Varcarolis Foundations of Psychiatric Mental Health Nursing, 8th edition, Chapter 32. Serious mental illness. The term severe mental illness refers to a group of psychiatric disorders, most of which are primarily biological in origin, that can significantly affect functioning and one's quality of life, especially if they go untreated. Other terms used interchangeably with SMI: broad-based mental illness, any commonly accepted mental health diagnosis; severe and persistent mental illness, similar to SMI but emphasizing chronicity; biologically based mental illness, illnesses that have been determined to be due to biological differences in the brain. SMIs include major depressive disorder, bipolar disorder, schizophrenia, schizoaffective disorder, panic disorder, PTSD, borderline and antisocial personality disorder, and OCD. In 2014, almost 10 million adults, about 4% of all adults, in the United States lived with SMI. Figure 32.1 illustrates the prevalence of SMI based on demographic characteristics. SMIs are usually lifelong disorders. Some patients experience remissions interrupted by exacerbations of various length. Sometimes the remissions are essentially symptom-free, but more typically, there is some degree of residual symptoms. For others, the illness follows a chronic and sometimes deteriorating course, during which symptoms wax and wane, but never remit. SMIs are devastating. Individuals with SMI are more likely to be victims of crime, have medical illnesses, often undertreated or untreated, and die prematurely. They are also more likely to experience homelessness, be incarcerated, be unemployed or underemployed, live in poverty, and engage in substance misuse. People with SMI often struggle with activities of daily living, functioning at work or school, relationships, social interaction, coping, communication, and task completion. They may also experience impairment related to leisure activities, health maintenance, vocational academic activities, remaining safe in the community, and managing finances. They can experience difficulty exercising sound judgment, controlling impulses, concentrating, and coping with everyday stressors. These impairments, along with related factors such as poverty, stigma, unemployment, and living in high-crime areas, reduce access to health care. Inadequate housing can significantly impact quality of life and can cause people with SMI to live in a parallel universe separate from normals or neurotypicals, names sometimes used to describe people without mental illnesses. Stigma, others' irrational fear of mental illness, and the patient's residual symptoms or socially inappropriate behavior can cause others to avoid the patient and refuse them housing or employment. In this chapter, we refer to people with serious mental illness as consumers. The term consumers indicates the potential for active participation in treatment and empowerment of the individual for this participation. SMI can affect individuals of any gender, age, educational level, culture, or location. However, those living with SMIs can be separated into two groups based on their experience with the mental health system. One, those old enough to have experienced the long-term institutionalization, usually before 1980. And two, those young enough to have been hospitalized only for brief acute care and receiving most of their care in the community. Older adults with SMI probably received care in the state mental hospital system, where patients lived in hospitals and were treated by professional staff. This institutional inpatient care model was considered the most effective and was welcomed by communities and families who struggled to provide care for this population. Care was regimented, care was often poor, and human rights violations were common. Patients had little say in their treatment. As a result, older adults may have become institutionalized or adapted to life in institutions, or others made decisions for them. For these people, transition to independence in the community care has been difficult. In addition, older adults tend to require more care for medical conditions, including those related to their mental illness, such as diabetes and metabolic syndrome. As a result, many older adults are cared for in nursing home settings instead of in the community. Younger adults. People without a history of institutionalization usually do not have problems of passivity and dependency. Instead, most experience a series of short-term hospitalizations. These hospital stays stabilize the illness, but often fail to overcome issues such as not recognizing the need for treatment and resultant treatment non-adherence. This has contributed to a cycle of treatment, brief recovery, non-adherence, or relapse. Intermittent treatment puts young adults with SMI at particular risk for additional problems. Problems include increased frequency of relapse, arrest and incarceration, homelessness, substance abuse, unemployment, and poor long-term prognosis. Development of SMI. SMI has much in common with chronic physical illness. The original problem increasingly overwhelms and erodes the ability to cope, which results in new problems. For example, in CHF, the lungs and kidneys deteriorate due to cardiac insufficiency. Similarly, a person with schizophrenia may experience paranoia and a loss of social skills, causing interactions to become more and more anxiety-provoking. The patient begins to withdraw and experiences avoidance by others. This results in increased isolation and lack of support when support is most needed. As a result, coping abilities and functioning continue to deteriorate. Rehabilitation versus recovery, two models of care. For many years, the concept of rehabilitation, which focused on managing patients' deficits and helping them learn to live with their illness, dominated psychiatric care. Staff directed the treatment and focused on helping patients to function in their daily roles. The goal was to stabilize the disability. Recovery from SMI was unthinkable. Advocacy movements in mental health produced sweeping change. First, patients with SMI began to refer to themselves as consumers, to emphasize the choices they have or seek to have over their treatment and lives. Then this consumer movement criticized the rehabilitation model as being paternalistic, focused on living with disability rather than on improving quality of life and achieving recovery. The recovery model, which has its roots in the substance abuse community, developed out of this consumer movement. The recovery model is supported by NAMI, National Alliance on Mental Illness, a leading mental health consumer support and advocacy organization in the United States. The recovery model is patient, consumer-centered, is hopeful and empowering, emphasizes the person in the future rather than the illness in the present, involves an active partnership between patient and care providers, focuses on strengths and abilities rather than function and disability, encourages independence and self-determination, focuses on achieving goals of the patient's choosing, not staff's, emphasizes staff working collaboratively with consumers, building on strengths to help consumers achieve the highest possible quality of life, aims for increasingly productive and meaningful lives for those with SMI. Issues confronting those with serious mental illness. Establishing a meaningful life. Finding meaning in life and establishing goals can be difficult for people living with SMI, particularly if they also experience poor self-esteem. Patients struggle with the possibility that they may never be the person they once expected to be. It is helpful to find ways to reset goals so that meaning can be found in new directions, such as helping others, volunteering, or even successfully managing their illness. This reset is important to achieve a satisfactory quality of life and to avoid despair. If a person cannot work or attend school, there's a significant amount of free time to fill. This free time can result in boredom and stagnation. Options for constructive use of leisure time are limited if a person doesn't have transportation or lacks money. Helping the patient discover affordable options to structure free time and bring pleasure to life is important. Helpful options include borrowing movies, magazines, or books from the library, also usually a nice environment to spend time, going for walks to nearby parks or in malls, and going to free or low-cost concerts. Joining a clubhouse or gay program can counter social withdrawal, increase social skills, and help build support systems. Comorbid conditions. Physical disorders. People with SMI are at greater risk for co-occurring physical illnesses, particularly hypertension, obesity, cardiovascular disease, and diabetes. The risk of premature death is over 3 times greater than the general population, and on average, patients with SMI die more than 25 years prematurely. Contributing factors include failing to provide for their own healthcare needs, e.g., forgetting to take medicine, inability to access or pay for care, higher rates of smoking, poor diet, criminal victimization, and stigma. A mental illness can distract healthcare staff from the patient's real medical needs. They may feel or be told that they are unwelcome in clinic waiting rooms because of their behavior, appearance, or hygiene. Also, expressing health concerns in an eccentric or unclear manner can influence quality of care received. One patient with schizophrenia experienced priapism, a medically dangerous extended period of erection, as a side effect. Due to psychotic thinking, he interpreted the pain to emergency department staff as demons sticking needles in my penis. The resident did not assess for priapism partly because of the bizarre description. His assumption that the patient's distress was due to his mental illness and possibly his own discomfort working with his population. There is a strong support for integrating mental and physical health care in a single setting to enhance access, improve coordination, and facilitate staff understanding and communication. One example is for mental health centers partnering with primary care providers so that their consumers can receive both forms of care in a single coordinated delivery setting. Depression and suicide. Suicide occurs 12 times more frequently in people with SMI. For example, half of those with schizophrenia attempt suicide, and 1 in 10 succeeds. Consider a successful pre-med student who developed SMI, then 3 years later finds herself unemployed and living in a group home. There is a significant disconnect between her former life path and her current situation. This loss of what might have been can lead to acute or chronic grief that, along with the chronicity of the illness and its demands and impact on daily life, can contribute to despair, depression, and risk of suicide. Helping the patient find support, caring, meaning, and value to life can avert suicide. Substance use. In 2013, 1% of all adults age 18 or over in the United States had a co-occurring substance use disorder and SMI. Substance use in this population is primarily alcohol and marijuana. It can be a maladaptive response to boredom or a form of self-medication, countering the dysphoria, anxiety, or other symptoms caused by illness or its treatment, e.g., the sedation caused by one's medications. Substance use significantly increases the risk of relapse and impairs judgment and impulse control. While cigarette smoking has declined among the general population over the past decade, there has been little change among people with SMI. For example, more than 80% of people with schizophrenia are nicotine dependent. The prevailing belief that nicotine is a form of self-medication that improves cognitive ability has not been supported by research. Nicotine can, however, reduce the effectiveness of certain psychotropic medications. Cigarette smoking contributes to comorbid physical health problems and reduced quality of life. Social problems. Stigma. Stigma is the perception that an individual is flawed. The perception is covertly or overtly linked to some personal defect in the person being stigmatized. A lack of understanding and incorrect beliefs about mental illness result in stigma about SMI. For example, some may believe that people with SMI are violent when in fact violence is rare. Nonetheless, the result of this stigmatizing belief is fear and avoidance of people with SMI, particularly those who have psychotic disorders. Stigma can cause shame, anger, and isolation in the consumer and can lead to discrimination in healthcare, housing, and employment. It is often hard to grasp that individuals can recover from mental illness. This is mostly due to stereotypical images of mental illnesses and limited corrective contact with people with SMIs. Initiatives such as NAMI's #IamStigmaFree program seeks to improve understanding and acceptance through public education and reduction of stigma. Isolation and loneliness. Social isolation and loneliness are concerns with SMIs. Stigma, poor self-image, passivity, impaired hygiene, similar factors reduce interaction and interfere with relationships. Romantic relationships and opportunities for sexual expression are usually desired, but isolation, which may be compounded by sexual dysfunction from medication, reduces the chances. Dating services specifically for people with SMI can be helpful. Support groups such as NAMI provide for interaction in a supportive, low-stigma environment and provide opportunities to practice social skills, develop social comfort, and establish relationships. Victimization. Stereotypes suggest that people with SMI are more likely to be violent than people without mental illness, but the reverse is actually true. People with mental illness are more likely to be victims of violence than perpetrators. Sexual assault or coerced sexual activity also occurs in this vulnerable population. Impaired judgment, impaired interpersonal skills, e.g., unknowingly acting in ways that might provoke others, such as standing too close. Impaired facial recognition, e.g., not recognizing irritation. Poor self-esteem, dependency, and appearing more vulnerable to criminals may contribute to victimization. Drug use and poor living conditions in high-crime neighborhoods increase the risk of victimization and can worsen the psychiatric condition. Economic challenges. Unemployment and poverty. Most people get at least part of their identity and sense of value from the work they do. Many people with SMI would like to work. However, symptoms such as cognitive slowing or disorganization interfere with obtaining or succeeding at work. 85% of people with SMI are unemployed, and disability entitlements do not provide much income. Finding an employer open to hiring a person with SMI can be difficult, and anti-discrimination laws do not guarantee a job. Figure 32.2 illustrates the employment rates of people with SMI. Newer medications can be extremely expensive, over $1,000 a month. Copays or Medicaid spend downs, the monthly need to exhaust personal funds to continue Medicaid eligibility, are obstacles to treatment. Individuals with insurance may find that their share of costs is prohibitively high, that their insurance provider limits mental health care coverage or does not cover it at all. Providing mental health care coverage equal to that for physical health care or insurance parity is required under the Affordable Care Act. Yet insurers still treat mental illness differently, such as requiring pre-authorization for care when pre-authorization is not required for comparable physical health care. Housing instability. People with SMIs often have limited funds and thus limited housing options. Affordable housing may require living far from resources such as stores, healthcare, and support people, or living in unsafe neighborhoods. As an adult who expects autonomy, living with parents can be extremely challenging and may result in conflict and volatility. Behaviors such as non-adherence and impaired self-care can disrupt housing with family and lead to estrangement. An episode of inappropriate behavior could lead to eviction and a negative reputation among landlords, closing doors to future housing. Police may not recognize symptoms of mental illness, leading to arrest. Imagine a consumer who is experiencing hallucinations. She becomes disruptive and is arrested instead of police de-escalating the situation. This arrest can potentially leave the woman ineligible for housing subsidies or public housing. Even with a subsidy, waiting lists might be several years long. Finding and keeping good housing can be challenging. Consumers can also lose housing due to extended hospitalization. Fortunately, options such as no reject, no eject housing is becoming common. These are group homes that hold a consumer's room even if hospitalized. Medicaid will now cover housing in some cases. Caregiver burden. Caregivers, particularly family members, are challenged to cope with the persistent needs of people with SMI and may find themselves unable to shoulder the burden. They report that navigating the mental health system is challenging and stressful. Due to stigma or isolation, caregivers carry this burden with little support, emotionally and financially. Ensuring that caregivers are connected with resources and connecting the patient with services that will increase independence, such as vocational and housing support, are essential nursing interventions. Caregivers also age, become ill, and require care themselves, often creating a difficult adjustment when a caregiver can no longer provide care or housing. Planning for the transition for family caregivers to independence before a crisis occurs and making arrangements for financial support, such as living trusts, when finances allow, can preserve stability and avert relapse. Box 32.1 recounts a family member's difficulty in living with a brother who has an SMI. Box 32.1. My brother with a severe mental illness. In ordinary circumstances, family relationships are challenging. Adding a sibling with serious mental illness can create challenges that are, at times, insurmountable. In my family's case, my younger brother began exhibiting odd behavior in late adolescence, mostly walking the street at night and making irrational statements. He claimed that he was switched at birth with my youngest brother. John, the sixth of 7 children, was intelligent, entertaining, and well-liked in school. When John's symptoms began to surface, my parents did not attribute the behaviors to a psychiatric disorder. However, when John suffered a freak head injury involving a garbage dumpster lid and was subsequently treated for the injury, the focus shifted to mental illness. Now 60 years old, my brother has had intense psychiatric care, including forced hospitalizations and periods of being legally judged incompetent. Our father tried to care for him and meet his needs while my brother's delusions caused his son to deny him as his natural father. He is convinced that he has a Russian mother, even though our non-Russian mother passed away nearly 30 years ago. In addition to losing all his childhood friends long ago, his behavior has served to alienate nearly all of his siblings. Since our father passed away, we are trying to help John, but it is difficult. The privacy rules associated with the Healthcare HIPAA Act restrict sharing his healthcare information. So far, he has been unwilling to sign a release. The hospitalizations are occurring more frequently, and the medications seem to be losing their effectiveness. Recently, he indicated that he has considered suicide. As a result, we have been forced to seek a court-appointed guardian for him. Treatment issues. Enaz, Agnosia. The inability to recognize one's illness due to illness itself affects most of those with SMI. In SMI, the illness affects the one organ needed to have insight and make good decisions, the brain. As a result, it can take months or years for a person with SMI to recognize and acknowledge his or her mental illness. Some may assume that the patient is in denial. While this can happen, Agnosia is much more likely in SMI. Table 12.3 in Chapter 12 includes interventions for Agnosia. Non-adherence. More than half of all people with mental illness are not receiving treatment or are non-adherent to treatment. This can quadruple the likelihood of relapse. Agnosia, side effects, medication costs, lack of trust in providers, and the stigma of mental illness also cause non-adherence. Factors that promote adherence, such as establishing a trusting therapeutic alliance, can be neglected. Healthcare providers often respond primarily with medication education and pointing out the consequences of non-adherence. But patients faced with repetitive medication groups and exhortations to take medications often become more resistant rather than insightful. Box 32.2 describes more effective nursing interventions that promote adherence. Box 32.2. Encourage careful selections of medications that are most likely to be effective, well tolerated, and acceptable to the patient. Actively help the patient to manage side effects to avert and minimize the stress that could cause non-adherence. Simplify treatment regimens to make them more acceptable and understandable to the patient, e.g., once-a-day dosing instead of twice. Tie treatment adherence to achieving the patient's goals, not the staff or society's, to increase motivation. Reinforce improvements, e.g., such as living in the community without rehospitalization, connecting them to treatment adherence. Assign consistent, committed caregivers skilled at building trusting therapeutic relationships and who will be able to work with the patient for extended periods of time. To improve patient insight and motivation, educate the patient and family about SMI and the role of treatment and recovery. However, education alone will not lead to adherence, particularly for people with Enaz agnosia. Minimize obstacles to treatment by providing assistance with treatment costs and access. Involve the patient and family in support groups with members who have greater insight and first-hand experience with illness and treatment. People whose viewpoints the patient may be more likely to appreciate and accept. Peer support specialists could be especially helpful here. Provide culturally sensitive care, not attending to cultural beliefs and practices, e.g., mistrust of healthcare and authority figures, or valuing self-sufficiency or privacy above healthcare, can result in rejection of the treatment. When other interventions have not been successful, use medication monitoring or long-acting forms of medication, depot injections or sustained release forms, to increase the likelihood that needed medication will be in the patient's system. Note, mouth checks may not find pills hidden in the patient's mouth. Engaging the patient in conversation for several minutes after he takes the pills is also of limited benefit. For people on oral medications, fast dissolving or liquid forms are the best option for ensuring their ingestion. Never reject, blame, or shame the patient when non-adherence occurs. Instead, label it as simply an issue for continuing focus and accept that achieving adherence often requires numerous tries. Remind yourself that non-adherence is common and often is due to agnosia in the illness itself. Medication side effects. Psychotropic medications can produce a range of distressing side effects, from involuntary movements to increased risk of diabetes. Some side effects, e.g., dystonias, are treatable. Others may diminish over time, or the individual can compensate for these through behavioral changes. For example, one simple response is to changing position slowly to reduce dizziness from hypotension. Addressing side effects is essential to promote adherence and maximize quality of life. Referring to Chapter 3 for a detailed discussion of drugs used in treatment of SMI, to chapters on individual disorders for nursing care related to side effects. Treatment inadequacy. NAMI evaluates services provided to those with SMI and finds most states lacking. The most recent group ratings gave below average ratings to 27 states. The highest grade of B went to only 6 states. NAMI cited the following problems: fragmented and inadequately funded services, inadequate housing, excessive institutionalization. Although standards of care now exist for most SMIs, providers do not always follow them. Instead, consumers must be informed and diligent in ensuring that they are receiving the most effective treatment, and agencies and staff must be diligent in updating their programs and practices. Residual symptoms are those that do not improve completely or consistently with treatment. This can be frustrating, and patients may feel these symptoms mean they will not get better or the treatments are not working. This leads to helplessness and despair. The patient may discontinue treatment in response, worsening the illness. Relapse, chronicity, and loss. The majority of patients with an SMI face the possibility of relapse, even with exactly adhering to treatment, which may contribute to hopelessness and helplessness. Living with an SMI paradoxically requires more effort and emotional resources from people less able to cope with such demands. Each relapse can cause loss of relationships, employment, and housing. Adding that much more loss to the patient's life and making discharge planning significantly more complicated. SMI resources. Comprehensive community treatment. Ideally, the community-based mental health care system provides comprehensive, coordinated, and cost-effective care for the consumer with mental illness. However, in 2003, the President's New Freedom Commission on Mental Health concluded that services, particularly for SMIs, were fragmented and inefficient with blurring of responsibility among agencies, programs, and levels of government. Many consumers fall through the cracks, and those who receive treatment had difficulty achieving financial independence because of limited job opportunities and the fear of losing health insurance in the workplace. Becoming employed and having an income may cause ineligibility for Medicaid or Medicare. The goal of community psychiatric treatment is to improve the consumer's ability to function independently and achieve a satisfying quality of life. Community mental health centers, private providers, psychs, psychologists, counselors, social workers, and APRNs, and other private, public, and governmental agencies provide outpatient care. Community services vary with local needs and resources. Rural communities or those with limited finances may provide only mandated services and limited access to them, whereas other communities may have a broad array of accessible services. Needed services may be unavailable or have long waiting lists due to funding cutbacks, and consumers may have difficulty finding the services they need amid the maze of agencies and services. Community services and programs. The public healthcare system provides most care to those with SMIs. This system uses tax support to provide services even to those who are indigent or without adequate or any health insurance. Community mental health centers typically provide psychiatric or medical somatic services and prescribe and monitor medications. Psychiatrists, advanced practice psychiatric mental health registered nurses, and sometimes physician assistants provide these services along with support from basic licensure nurses. Case management helps patients with day-to-day needs, treatment coordination, and access to services. Paraprofessional staff, people trained to assist professionals, usually provide this care. They work in the patient's home, school, and vocational settings and coordinated overall care, facilitating access to services while providing basic education, guidance, and support. Case managers may provide medication monitoring, observing and facilitating the patient's use of medications to promote adherence. One evidence-based model of case management for patients with SMIs is assertive community treatment, discussed later in this chapter. Day programs provide structure and therapeutic activities to patients who attend the program 1 or more days a week. Services often include education regarding social skills, ADLs, and pre-vocational skills. Day programs also provide social contact and peer support. Staff monitor the patient's status so that they can detect and address concerns quickly. A variety of staff and sometimes consumers themselves provide day program services. Peer support specialists, that is, other consumers who are in recovery, may provide some of the services. Individual and group psychotherapy includes counseling and therapy based on a variety of models, usually provided by independently licensed mental health professionals. Psychotherapy approaches for SMI include 1. Family therapy, helping family members function more effectively by providing skills and knowledge necessary to support loved ones. 2, psychoeducation groups, educating about mental health topics such as psychotropic drugs and skills, conflict resolution. And 3, support groups, providing support related to daily challenges of living with chronic illness. This chapter discusses 3 other approaches: cognitive therapy, cognitive behavioral therapy, and supportive psychotherapy. The following services may be provided by community mental health centers or through other public and private agencies. Crisis intervention services focus on helping patients regain their ability to cope when facing overwhelming stress, such as psychological trauma or relapse. Impaired cognition and problem solving increase the risk of crisis in people with SMI. Stressors, such as changes in routine at home or work, physical or financial problems, victimization, or anniversaries of traumatic events, may overwhelm coping and result in crises. A person with SMI and limited coping abilities may respond to small stressor first by seeking hospitalization. Crisis intervention seeks to help that person manage the stressor in less restrictive settings and avoid more disruptive inpatient care. Crisis intervention emphasizes finding new support or calling on existing resources for additional support. Crisis services range from staff on call who provide direct support 24 hours a day by phone or in person, to support lines or warm lines for lower levels of distress, or hotlines for crisis and higher levels of distress. Providing phone-based screening, support, crisis intervention, and referral services. Crisis residential or stabilization programs in some communities typically provide a stay of several days to 2 weeks when acuity is too great to remain a community residence, but not high enough to require hospitalization. Emergency psychiatric services provide emergency assessments, crisis intervention, sometimes emergency medications or adjustments. Individuals with SMI may be unable to recognize that the illness is worsening or that they are becoming unsafe. Therefore, most communities provide 24-hour emergency psychiatric evaluation program that can initiate emergency inpatient admissions on an involuntary basis. An additional emergency service is a mobile crisis team. It is composed of mental health professionals who go to residences, jails, or even street corners. Some communities' law enforcement officers are responsible for initiating involuntary emergency psychiatric evaluations. Local probate courts can also order such evaluations upon petition by family members or other interested parties. Housing services help people progress toward independent living and to maintain stability and avoid homelessness. Settings include supervised or unsupervised group homes. Boarding care homes provide room, board, and limited supervision by lay people in their homes. Housing services include independent community housing such as apartments and houses. Programming may target special populations such as individuals with a forensic history. This group includes criminal offenders who may have been found not guilty by reason of insanity, who no longer require inpatient care, but require special or intensive monitoring and programming in the community. Partial hospitalization programs, PHPs, often affiliated with inpatient programs, typically provide most of the services available to inpatients, but on an outpatient basis. Patients usually attend PHPs Monday through Friday for most of the day. Inpatients may be stepped down to PHP programs from inpatient units for further stabilization before being released to other community services. Outpatients may use PHP services to control symptoms in order to avoid inpatient care. Intensive outpatient programs are similar, but tend to be less lengthy. Patients may attend 3 to 5 days a week, usually for half a day. Community outreach programs often focus on homeless individuals or people who do not seek care on their own. Professional or paraprofessional teams work in the community to engage people with mental illness who are in need of services and to provide patient advocacy. Multi-service centers collaborate with outreach programs to supply hot meals, laundry, and shower facilities. They can also provide clothing, social activities, and transportation to and from services. For SMI people who are homeless or living in drop-in shelters, these centers provide access to phones and a mailing address, usually essential when seeking work or benefits. Substance abuse treatment. A variety of services exist for those who have a dual diagnosis of SMI and alcohol-related or drug-related problems. Substance disorder clinics provide therapeutic and rehabilitative services and medication-assisted treatments, such as detox or methadone. They also provide psychosocial interventions and psychotherapy. Help for families is also available. Most clinicians endorse integrated treatment that is delivered by a single provider rather than split between a mental health agency and a drug alcohol agency. Refer to Chapter 22 for a detailed discussion of treatment settings for patients with substance use disorders. Evidence-based treatment approaches. Assertive community treatment involves consumers working with a multidisciplinary team that provides a comprehensive array of services. This team approach eliminates the need for multiple departments or agencies to provide services. Research supports this model for improving quality of life and reducing inpatient admissions, incarcerations, and homelessness among people with SMI. At least one member of the team is available 24 hours a day for crisis care. The emphasis is on treating the patient within his or her own environment. Although ACT programs cost more to operate, proponents believe these costs are offset or reduced care costs elsewhere. CBT has been effective in helping individuals with SMI reduce and cope with symptoms such as delusions and impaired social functioning. The cognitive component of CBT focuses on patterns of thinking and self-talk. It identifies distorted thinking and negative self-talk and guides patients to substitute more effective ways of thinking. The behavioral component of CBT uses natural consequences and positive reinforcers to shape the person's behavior in a more positive or adaptive manner. Refer to Chapter 2 for a more detailed discussion of CBT. CET, or Cognitive Enhancement Therapy, is based on the principle of neuroplasticity, that healthier areas of the brain can assume neurological functions for the compromised area of the brain. CET is a lengthy process of structured, computer-based drills and group exercises, e.g. 60 or more, that incrementally challenge and strengthen functions such as focusing attention and processing and recalling information. It can also help with interpreting social and emotional information such as judging a person's mood from his or her expression or tone of voice. Research has shown that CET leads to sustained improvement in cognition and improved social and vocational functioning. Family support and partnerships. Families and significant others can face significant stresses related to the mental illness of a loved one, and both may suffer from insufficiencies in empathy and understanding. Sound family support is one of the strongest predictors of recovery. When treatment providers work as empathic partners, patients, and significant others, this enhances treatment and reduces conflict. NAMI's family-to-family program focuses on understanding SMI, coping skills, and the recovery process. NAMI meetings and support groups specific to various SMIs, for example, the Depression and Bipolar Support Alliance, serve as excellent sources of support and practical guidance for primary consumers and secondary consumers. their significant others. Social skills training is an evidence-based practice that focuses on teaching a wide variety of social and ADL skills. People with SMI often have social deficits that cause functional impairment. For example, a person may not realize that standing too close causes discomfort to others and can lead to negative outcomes, such as rejection or poor job evaluation. Care providers break down complex interpersonal skills, such as resolving a conflict, into more manageable subcomponents. They then teach them how to deal with the problem step by step. They also use role-playing and group interaction to practice skills. Vocational Rehab and related services. Consumers with SMI who are employed experience improved socialization, confidence, organizational ability, socialization, income, and quality of life. Vocational services or vocational rehabilitation typically include training skills to enhance employment and financial support for retaining employment. Day programs may use a clubhouse model in which consumers run the programming. Consumer-run businesses such as a coffee shop or housekeeping service teach all members to perform a job in the business. Such programs have led to supported employment model, which has been shown to be more effective in helping individuals with SMI achieve employment. Elements of this approach include 1. Financial incentives to employers to employ people with SMI. 2. Rapid placement in a competitive job preferred by the patient. 3. Continued individualized support on the job, e.g. a coach at the worker's side providing support, guidance, and training, coordination with supervisors. 4. Integration of mental health and employment services. Other treatment approaches. Court-involved intervention. Psychiatric advance directives are legal documents that allow an individual whose disorder is in remission to direct how to manage treatment if judgment becomes impaired during a relapse. For example, when well, consumer can agree to accept hospitalization or medications should he or she experience a relapse. This proactive plan helps the consumer maintain control over treatment and avoid the need for involuntary admission and court involvement. Guardianship involves the appointment of a person to make decisions for the consumer during times when judgment is impaired or is disabled with Enaz Agnosia. Guardians may be significant others or attorneys. They are typically appointed during a court process addressing the issue of whether or not a patient is competent to provide for his or her own needs. Individuals who have been appointed a guardian typically may not enter into contracts, consent to sexual activity, or authorize their own treatment. All of those actions require the guardian's approval. In some cases, the guardian's authority is limited to the person's finances, as when a consumer is functional in most respects, but unable to manage money, placing basic needs for food and shelter at risk. The guardian is responsible for using the consumer's funds to meet such needs. An alternative is the use of a payee, often a volunteer or staff member, whom the consumer agrees to allow to manage his finances, usually via a contract. Consumer-run programs. As previously discussed with vocational rehabilitation, consumer-run programs may be informal clubhouses which offer socialization, recreation, and sometimes other services. They may also be competitive businesses, such as snack bars or janitorial services, which provide needed services and consumer employment while encouraging independence and building vocational skills. In Cincinnati, Ohio, for example, consumers working with a food service professional run a restaurant open to the public, both learning skills and developing experience in the food service industry. Community mental health centers typically have consumer-run programming as part of day programs. Peer support. Peer support involves receiving support from one's peers. That can be from untrained peers in a peer support group or be specially trained and sometimes certified peer support specialists. NAMI and other programs offer training that enables consumers to assist peers effectively in their recovery process. Peer support specialists may work in hospitals or day programs to encourage and help their peers. They draw on first-hand experience with SMI to enhance their effectiveness. People with SMI are often more open to accepting information from people who have experienced what they are going through. Wellness and recovery action plans and similar programs are psychoeducational programs that empower and train consumers in skills that promote recovery and prepare them to deal with stressors and crises. Training focuses on daily maintenance plans with actions and resources needed to maintain wellness, such as adequate rest and sleep. These programs help individuals to identify and manage triggers that could provoke a relapse, early identification of impending relapse, and crisis plans for managing crisis or impending relapse. Typically, they provide a wide variety of useful tools, templates, and techniques. Technology can reduce costs and improve treatment access and outcomes. Electronic records available in multiple locations can assist in assessments or promote continuity of care anywhere in the community. Those who cannot afford electronic access often have or can be provided with a cell phone, allowing for improved monitoring, faster response if, for example, a patient misses an appointment. Smartphone applications can help consumers manage stress, prevent weight gain through exercise or dietary means, and remember their treatments. Text reminders can promote treatment adherence by tracking medications or appointment. Medication dispensers that track when medications are taken are also helpful. Personnel in remote locations are now able to speak with patients by telephone or internet-based video when patients cannot otherwise access distant services or specialists. Exercise. Exercise holds benefits for people with SMI, including improved coping with symptoms, reduced anxiety and depression, and enhanced self-esteem. Exercise helps with weight control, which is essential for people with weight-related comorbidities such as diabetes and hypertension. Exercise is a cost-effective intervention that can be done almost anywhere. While SMI symptoms such as avolition are obstacles to exercise, motivational and group interventions can improve exercise participation. Nursing care of patients with serious mental illness. Nurses encounter patients with SMI in a variety of medical and psychiatric settings. All roles and techniques used by psychiatric mental health nurses in inpatient psychiatric settings also apply in the community and other healthcare settings. Assessment strategies. Important aspects of assessment include intentional risk to self or others, suicide or homicidality, unintentional risk, inadequate nutrition, clothing inadequate for the weather, neglect of medical needs, or carelessness while driving, smoking, or cooking. Depression or hopelessness, anxiety, signs of impending relapse, decreased sleep, increased impulsivity or paranoia, diminished reality testing, increased delusional thinking, or command hallucinations. Physical health problems that can cause psychiatric symptoms and be mistaken for mental illness or relapse, e.g. brain tumors or drug toxicity. Comorbid illnesses, to ensure that the patient provides appropriate self-care and receives adequate health care. Treatment non-adherence. Signs such as worsening of symptoms, unused medications, missed appointment, or reluctance to discuss these issues. Table 32.1 lists selected signs and symptoms, problems associated with SMI, potential nursing diagnosis that apply to the patient with SMI, and examples of specific nursing outcomes. Intervention strategies. Box 32.3 outlines two relevant nursing interventions classification. Interventions for the management of serious mental illness. Basic nursing interventions for patients with SMI are listed in the following text. Additional interventions are in Table 13.3 in Chapter 13 and other chapters covering individual mental illnesses. Involve the patient in goal setting and treatment planning. This increases treatment adherence and improves treatment outcomes. Emphasize quality of life rather than simply focusing on symptoms, as this conveys an interest in the person rather than the illness and promotes recovery. Maintain sustained therapeutic relationships. Trust in providers is key to overcome Enaz agnosia and achieving treatment adherence. People with SMI often require extended periods to form these connections. Focus on coping with current issues rather than past difficulties. Encourage reality testing to enable consumers to recognize and counter hallucinations and delusional thinking. For instance, if a person experiences frightened hallucinations while in public, he can learn to scan the room and determine if others seem frightened. If not, he can learn to attribute his experience to his illness and ignore the hallucinations. Enable consumers to recognize and respond to stigma. Stigma predisposes SMI people to isolation and social discomfort. The resulting isolation contributes to loneliness and reduces access to support. Promote social skills and provide opportunities for social isolation, especially with positive role models such as other patients who are further along in recovery. Involve consumers in support groups such as NAMI that expose them to members who have been there. Such groups provide support, socialization opportunities, and practical suggestions for issues and problems facing patients and significant others. Peer support specialists are another excellent resource for this purpose. Educate consumers about their illness and recovery. Understanding the illness enhances coping, treatment adherence, and quality of life. Care for the whole person. SMI patients have more physical illness, poorer hygiene and health practices, less access to effective medical treatment, increased risk for victimizations, STDs, and undesired pregnancies. They also have more premature mortality than the general population. Avoiding obesity through exercise and good nutritional practices can reduce the risk of comorbidities such as metabolic syndrome. Sound physical health conserves energy and resources for use in coping with SMI. Involving individuals with co-occurring substance use disorders in AA and NA and other dual diagnosis services. Substance use disorder rates are high in SMI populations. They increase relapse and interfere with recovery. Achieving sobriety is most associated with AA and integrated treatment programs. Evaluation. Identified outcomes serve as the basis for evaluation. Each NOC outcome has a built-in rating scale that helps the nurse to measure improvement. Current issues affecting those with SMI. Outpatient commitment. Voluntary inpatient care has long been used to treat those who are unable to recognize their illness and the need for treatment. Outpatient commitment, which provides mandatory treatment in the community, is relatively new. Typically ordered by a court when a patient leaves a hospital or prison, it is for people who would otherwise be unlikely to continue treatment, resulting in their becoming a danger to self or society. The practice of outpatient commitment is controversial. On the one hand, individuals who do not recognize having a mental illness are provided with health care, potentially a better quality of life. They are allowed maximum freedom and are able to live in the community and avoid institutionalization. On the other hand, this approach is paternalistic and is at odds with the recovery model of mental health care. Research on the effectiveness of outpatient commitment has demonstrated results that both support and reject this approach. Criminal offenses and incarceration. People with SMIs may commit crimes due to desperation, impaired judgment, or impulsivity. Most often they are nonviolent crimes such as petty theft or disorderly conduct. Police may also become involved with people who seem unable to care for themselves, have become a public nuisance, cannot be persuaded to accept treatment, but do not meet criteria for involuntary treatment, usually imminent danger to self or others. For example, a patient with impaired judgment without shelter in cold weather may stay in a laundromat for warmth. The presence of an unkempt person who is talking to herself and is not using appropriate personal space cause the other patrons to feel uncomfortable. If expelled, she is at risk of hypothermia. In such a case, the risk itself may not be imminent, and emergency hospitalization is not a legal option. Significant others or police may then seek the person's arrest simply for the patient's own safety. Most mental illness advocates believe that incarceration, even if for the patient's own good, is harmful. Imprisonment can lead to victimization, despair, relapse due to stress or overstimulation, loss of housing or employment, and inadequate treatment. Criminal convictions may make consumers ineligible for most housing or employment, trapping them in a cycle of release and reincarceration. Advocates instead support diversion from jail to clinical care. Interventions to achieve this include 1. Educating police so that they can identify mental illness, distinguish it from criminal intent, and connect people with SMI to help instead of jailing them. And 2. Establishing special mental health courts designed to intercept people whose crimes are secondary to mental illness. These courts employ specially trained officials with authority to order treatment in lieu of conviction, thereby avoiding the stigma and other consequences of conviction and incarceration. Deinstitutionalization and Trans-Institutionalization. Prior to the 1960s, people often lived long-term in state psychiatric hospitals. The newer treatments available in the 1960s improved many patients' conditions enough that they no longer needed to be institutionalized and can live instead in the community. Deinstitutionalization, the mass shift of patients from state hospitals into the community, began in the 1960s and has continued since. However, planned systems of community care needed by individuals with SMI did not always materialize, leaving them to fend for themselves without access to the services they needed. It is also common for patients to experience difficulty in adjusting to independence after years of being institutionalized. As a result, former patients ended up being readmitted to state hospitals or cared for in other kinds of institutions. Trans-Institutionalization is a shifting person or population from one kind of institution to another, such as a state hospital, jail, prison, nursing home, or shelter. For example, people who were discharged from state hospitals ended up homeless and subsequently were arrested for a variety of crimes. Now there are more people with SMI in prisons than in hospitals. Inadequate access to care. SMI often makes it difficult for individuals to work or find well-paying jobs with health insurance benefits. As a result, people with SMI tend to rely on the public mental health system, which is run by state and local governments, for services delivered largely by state hospitals and community mental health centers. One consequence of deinstitutionalization was that 90% of state hospital beds were eliminated, making it difficult to provide hospital care to many who continue to need it. Further, most public mental health services rely on state and local funding, and the economic recession that began in 2007 has resulted in funding cutbacks that have reduced already overwhelmed mental health and related services. Inpatient and outpatient services for children and adolescents are in especially short supply. The result is that delayed admissions and waiting lists for outpatient care are now commonplace. The Affordable Care Act and Medicaid expansion have resulted in dramatically more people with SMI having health insurance. However, even those with insurance who can use private care providers often find that there are still barriers to getting needed care, such as burdensome pre-authorization requirements that discourage or delay access to needed services.